I'd like to welcome everyone to today's AHRQ web conference on the role of health IT to improve medication management. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Derek White, and I will be moderating this webinar. I currently serve as the Division of Health IT Research Grants Manager in the Center of Evidence and Practice Improvement at AHRQ. This slide shows the agenda for today's webinar. Please also note that we are recording this webinar, and the recording will be available via the AHRQ Health IT YouTube channel in about 2 weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning, and were also available for download as you logged in today. We will also be sending them to participants via email following the webinar. We are pleased to have with us today an esteemed group of presenters. They include Dr. Karen Farris from the University of Michigan College of Pharmacy, Dr. Jeffrey Schnipper from Brigham and Women's Hospital and Harvard Medical School, and Dr. Margie Snyder from Purdue University College of Pharmacy. This webinar event is accredited by the Professional Education Service Group. For those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentation. It would also be emailed to you after this webinar. For the purposes of accreditation, let me note that neither AHRQ, TISTA, RTI, PESG, as well as planners, reviewers, or myself as the moderator have any financial interest to disclose. Presenter disclosures: Dr. Snyder has no financial interest to disclose. Dr. Farris is a consultant with QIO, and Dr. Schnipper is the principal investigator for a study sponsored by the Mallinckrodt Pharmaceuticals. Lastly, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentation to address participant questions. However, during presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to explain the benefits and challenges for using reinforcement learning, guided text messaging to impact medication adherence, discuss the evaluation of the smart pillbox used by patients during care transitions, describe the extent to which clinical decision support for community pharmacists delivered medication therapy management aligns with established human factors principles, and discuss the usability and usefulness of NTM CDS for community pharmacists. And now, it is my pleasure to introduce our first presenter, Dr. Karen Farris. Dr. Farris is a Charles R. Walgreens III Professor of Pharmacy Administration at the University of Michigan College of Pharmacy. She is the chair of the Department of Clinical Pharmacy and also faculty lead of digital education at the Institute for Healthcare Policy and Innovation. Dr. Farris studies medication adherence and reasons for non-adherence. She is currently working with the Michigan Oncology Quality Consortium to improve how medication adherence to oral oncolytics is assessed in the oncology practices and how medication self-management can be improved. And now, allow me to turn this over to Dr. Farris.
Good afternoon, everyone. So I'm going to be talking with you today about our reinforcement learning agent that we developed to guide text messages. The name of that project, our acronym for it was AIM at BP, so using artificial intelligence medication adherence texting for BP, for blood pressure. And I'd like to acknowledge the funding that we received from the University of Michigan through an M-Cube initiative, from our CTSA, MISHAR, We received a pilot grant, and then also our AHRQ funding, as you can see there. So as almost all of you on this webinar know, medication non-adherence is a problem, and it costs our healthcare system a significant amount of money. Importantly, when we think about hypertension, about 30% of patients have uncontrolled hypertension despite treatment. We also know that SMS interventions or texting interventions can improve patients' adherence. But what we don't really understand is the frequency of texting, how long we need to be texting. Does it need to be for 2 weeks or 6 months? And importantly, we know that things happen in people's lives. And our premise is that we need our text messaging to adapt. And so that's the point there. mHealth interventions, as currently designed, have limited ability to engage patients over time because they may not be adapting. So our objective was to apply AI methods, specifically reinforcement learning, which is a type of artificial intelligence, to develop a medication adherence system that would adapt text messages. Today, I'm going to be talking about 2 different studies that we did. Study 1 was a prospective single-group trial involving 19 individuals. Of course, individuals had to use an antihypertensive medication. They had to be texters. They had to have internet. And we collected data with self-report as well as bottle openings. And I'll spend just a bit of time on that study. In study 2, we did a randomized trial involving 50 subjects, and we partnered with a health plan where individuals at the beginning of our study were reported to have an antihypertensive PDC, or proportion days covered with medication, of less than 0.5 in the past year. And for this study, we used self-report, bottle openings, as well as prescription claims for our evaluation. This is the model that we use to think about the system that we developed. And what's important here are the reasons for medication non-adherence. And so the blue boxes really highlight the types of text messages that we developed for our project. So the first one, you think about intention. So we think about what does a person think about treating their hypertension. And then if we think about medication beliefs, that would be necessity beliefs or concern beliefs. And then an individual has to remember to take those medications, provided that they have that intention to do so. And then in our studies, we also provided what were called positive reinforcement messages. And I'll show you some examples of those messages in just a bit. So importantly, this was the basis for how we thought about our project and how we built our messages. So this slide shows you what really what reinforcement learning is. So let me just spend a bit of time walking through this diagram. So the agent is what we call our RL agent, and that's really the set of algorithms that make the decision to take a particular action. So in our particular study, the action was to send a text message, but importantly, we also included no message as an option. So the agent could send 1 of 5 text messages or no message, or that could be its action choice. So then the environment is actually the individual who is receiving the text message. In both of our studies, we set these up so that the text message would go about 15 minutes before their daily dose of their medication. Then the next thing that's important to think about is what's the reward for the agent. And so what that means is that the agent makes a decision to send a necessity belief message. Then it waits on the individual to do something, to send some sort of reward. And that reward in this study was opening the pill bottle. So the message would be sent, and then the agent is waiting to know if a pill bottle was opened. At the same time, we recognize that there is a context in which this process occurs. And so the state variables are those characteristics about the patient that we entered at baseline, as well as we developed some additional variables For example, whether a person opened their pill bottle the last 5 times they received a necessity belief question, for example. So those are the components of the RL system. And importantly, the agent is able to learn and then what's called exploit that learning, meaning that it knows what kind of message may work best for each individual, and it makes that calculation each time it's taking an action. But it continues to explore whether a different message could also be effective. So the notion of RL is that it exploits what it knows, but continues to explore different action choices so that it can come to the best application over time with many subjects. So I'm going to move now and talk about the 2 studies that we did. And in study 1, I'm going to focus on really what our questions were can we get this thing put together and can we make it work? So number 1, is it working? And then importantly, are the messages adapting? Because recall, that's really the premise of what we're saying is that, or what our thinking is that, we don't want to just send the same old message every day to an individual, take your medicine, take your medicine, take your medicine. So we want to determine if our messages are adapting. So I wanted to include this relatively complex picture to show you all the parts of our adherence system. And if you look on the right side of the screen, you can see the AHRQ backend. And so what that's telling you is that's the pill bottle. And you can see there a picture of the pill bottle, and I have a better picture of that on the next slide. And so the AHRQ backend would tell us, and we connected to it, and it would tell us if the bottle was opened. So then you have the database in the center that's bringing together the study entrance, which is the web interface, the RL engine, which is the algorithms and is making a choice about what kind or whether to send a message. And then we have the messenger component, which is directing Twilio, which is what we use to actually send messages to individuals. So that's the entire system that we put together. And so our real question was, did it work? So this slide shows you the picture of the pill bottle that we used for the reward. And so this was in 2015. So I would assert that we have even better technology now that we could use. So in this particular instance, the individual had a MEMS cap that sat on top of that bottle that you see. But to direct the information to the database at AHRQ, they had to put that pill bottle on that little, it was about the size of a coffee cup holder, and they had to put that on that device upside down. So you should already be thinking, that's a bit obtrusive. That's an extra behavior that a person had to do to receive their messages. And so we agree with that, and we have some thoughts about that for future work. So this is a description of the 5 types of messages. If you think back to that model I showed you, these will all link to those particular items that I talked about. And so you can see examples of disease belief messages. An example of a remembering strategy message would be to help remember your blood pressure medications. Try putting your bottles near something you see every day, like your toothbrush. So again, our agent would select one of these messages or no message every day to interact with the individual. Now, if it was no message, then of course there was not an interaction. Okay, so just to be clear about that. So one important thing that we need to be thinking about is when we develop messages, and we're experts and we sit around and we develop our messages, it's important to know if they are perceived in the manner in which we intended. So we did 2 different card sorting studies. We did one with university staff, and we did another one with student pharmacists. We gave them random samples of our 5 different kinds of messages, and we asked them to put them in stacks or buckets, as I call them, different categories, if you will. And so this is a heat map that shows you for categories 3, 4, and 5, which are on the right. Those are very well defined. The 2 in the left upper quadrant, which would be necessity beliefs and disease beliefs, there's less discrimination, but we know that in our second heat map, which I don't have here, we had a little better differentiation. But we determined that these were sufficiently different messages from this type of analysis. So this slide shows you the results from our first study, which is just looking at, did the messages change over time? So what you see here is the distribution of messages that were sent in the second month compared to the distribution of messages that were sent in month 6, or the last month. And you can see that the distribution did change. So for example, 32% of the messages were necessity in the second month, and they turned into 24% by the 6th month. You can see remembering strategies was 13%, and that increased to 23%. So based on that work, which was our before-after, we had the messages being sent, people were receiving them, and we could see that the distribution of those messages was changing over time. So therefore, our view was that our RL agent was adapting. So in study 2, we were interested in whether the device continued to work, the agent continued to work, but importantly, was adherence changing, and what did participants think about it? So these are the baseline comparisons of the individuals who participated in our study. And let me remind you that this was a randomized trial. Everyone in the study had the reward, had the pill bottle. Treatment and control both had the pill bottle. And the intervention was really around the messaging. So people in the intervention group were receiving messages, but everyone was monitored for pill bottle openings. What this information shows you here is the baseline comparisons of individuals who were in the study. Importantly, you can see that that PDC was very low according to the records that we received from our health partner, and there were no other statistically significant differences based on those demographic information or in their literacy or actually in self-reported adherence. Even though it looks different, the numbers were not there to show that that was different. This you've seen is a similar representation you saw earlier. It's the distribution of messages over time, month 1, month 3, and month 6. What we did a bit differently in this trial was we, for lack of a better term, we biased the agent to make a decision toward not sending a message. And so what that means is if the agent determined that the messages had a similar probability of being selected, and if no message was an option, it would go with that option. And we did that based upon some feedback from our first trial, which I didn't share with you, that said we might have been messaging a bit too much. These are the actual pill bottle openings, and so you can see the control, and then you can see the group that received the messaging. And what you can see is that the green is perfect adherence, the red is very poor adherence, and the yellow is less than 100, but certainly still really good, above 80. So what you see is more green in the messaging. Importantly, you see everybody had pretty good adherence when they started this trial. Even though our PDC was quite low, when we brought them into this trial and everyone was being monitored, they were quite good at taking their medications. So you see more perfect adherence in the messaging group, particularly early on in months 1, 2, and 3. You also see more variability over time in the messaging group. But remember, we also were sending fewer messages at that time as well. These data show you the self-report, and so these are differences between baseline and 3 months for the people who got messages and the people who did not get messages. And what you can see is that at month 3, there was an improvement in medication adherence, a difference between the two groups, and at 6 months, that difference was no longer there. And again, this was a self-report of medication adherence. This has a typo. That's too bad. It's supposed to say PDC for the antihypertensive medication by group over time. So the red line represents the individuals who receive text messages. The solid line is the group that only had the pill bottle. And these time frames represent, on the most left, 1 year out before the trial. The midpoint is 6 months before the trial. And then the rightmost data points represent during the 6-month trial. And you can see those PDCs based on the claims we received at the end of the trial at the bottom. And so you might want to note the PDCs just prior to the trial are quite a bit higher than what we had been reported or told that they were. So, but this is still our calculation of the change over time. It is not a statistically significant difference. The trend is in the correct way, but it is not different. And then quickly, this slide represents some early analysis that we've done that says to us that there are a couple of different groups responding differently to different messages. And so if you look at the reddish color, that individual is actually quite different and was not responsive really to any of the messages, whereas you see the blue bar, those folks were responsive to every message and you couldn't even differentiate what type of message was best for them. If you look at the bottom group of individuals, you can see that medication necessity was help them more so than the other types of messages. So again, this is very preliminary, and we really need, honestly, way more people to get a good sense of what type of individuals respond best to what types of messages. And then my last data point is just to share with you some feedback. And of course, we have way more feedback than this, but this is just to give you a sense of it. So even at 3 and 6 months, individuals were telling us that the frequency of messaging was about right. So remember, we bias the agent to know messaging over time. So individuals were getting fewer messages, and we're still very happy with that. But again, what we also saw was that their adherence was slightly poorer, if you remember those pill bottle opening data. You can see here in the middle that they were saying 1 message a week, a few times a week. Again, I think we don't have good data. We don't have good results in this trial or in other studies about this messaging frequency. And then ask if they would enroll in something like this. Again, 40 to 50% said yes, that they would, and about the same amount said no, they wouldn't. So certainly there are a group of people out there who would enjoy having this type of support with their medications. So what did we learn, or what are some of the issues that I think we face moving forward? What we know is that this agent adapted over time. Its impact on non-adherence is mixed. The self-report was improved at 3 months. I think early on, the adherence we saw was really positive in the messaging group, but over time that did deteriorate. Importantly, an intervention to improve medication adherence needs to be delivered to individuals who are non-adherent, or it's too difficult to show a difference over time, and it's really not needed. So while our early data showed that these were individuals or were reported to be non-adherent, when we looked at the claims afterwards, it certainly didn't seem that that was quite correct. And so there's some disconnect between that. My point would be that if we had people who were really adherent already, trying to improve that is difficult. Our recommendation would be to think about how we could recruit into a study like this via uncontrolled disease. And then importantly, in the next point, how we could use an unobtrusive measure or unobtrusive reward, such as number of steps. So we're thinking about, and we're doing some work toward moving this agent into treating heart failure, or helping to manage heart failure, where number of steps would be the reward, and we would have adherence messaging, but we would also have other types of messaging, such as an individual managing their diet. I think importantly, even with an RL system, the system can learn to send no message so that you're not just constantly messaging individuals. But I think we need a lot more work around, is there a loading dose for messages? Do we really need daily messages? Or can we load and then booster, for lack of a better term, over time? Okay. So, in closing, text messages improve self-reported adherence at 3 months, not at 6 months. Pill bottle openings, however, showed little variability. The adaptation of text messaging did work. Individuals indicated one message per day, or one every 2 to 3 days was generally preferred. And our next steps, as I said, are really to put this in a place where we can work with heart failure patients, but I would be really interested in how we might partner with someone around using this agent with high-cost specialty medications. And then finally, I must thank this great group of investigators. We had engineers, we had health services researchers, I study medication adherence. So I don't think that this was a project that could have been done with me alone or even with the engineers alone. So we really needed this team to get this done, and I owe a debt of gratitude to these individuals shown here. Thank you.
Thank you, Dr. Farris. As a reminder, we will be taking questions after the presentations, so please submit any questions you have for Dr. Farris using the Q&A panel. Let's move on to our second presentation of this webinar, which is being led by Dr. Jeffrey Schnipper. Dr. Schnipper is an associate professor of medicine at Harvard Medical School, associate physician at Brigham and Women's Hospital, and the director of clinical research for the Brigham Health Hospital Medicine Unit. He is also the director of a new Harvard Brigham Fellowship in Hospital Medicine Research. He received his MD from Harvard Medical School in 1996 and completed a residency in internal medicine and primary care at Massachusetts General Hospital. His research interests focus on improving the quality of healthcare delivery for general medicine patients. And now, I would like to turn the controls over to Dr. Schnipper.
A smart pillbox being used during transitions of care. So here's the outline of what I'm going to cover in the next 20 minutes or so. First, a little bit of background on why we conducted this study. I'll spend some time giving you a description of the smart pillbox intervention. I'll show you the flow diagram of how everyone did in the trial. Spend a lot of the time talking about barriers to implementation of this intervention, and then move on to a discussion of what it would take to make this intervention part of usual care. And then I'll do next steps and conclusion. And as Commander Wyatt just said, we'll do the Q&A after all 3 presentations are over. So first, a little bit of background. So as many of you probably know, the transition period between the inpatient and the outpatient settings is a really potentially dangerous time for patients, especially when it comes to medication safety. Adverse drug events or injuries due to medications often occur after discharge. So they're very common and they're potentially serious. 2 of the reasons why these adverse drug events occur are patients' misunderstanding of their medication regimen, so they're not even sure of what medications they're supposed to be taking after they leave the hospital. And then even when they are aware, they're often non-adherent with those regimens. And we've done a number of studies using patient education and feedback and phone calls, and they've all been less effective than expected when they've been studied rigorously. So while technology isn't always the answer to all of our problems, we thought that this was a good place to try some, and there's been a lot of new technology that's been created over the last few years. So what you see in front of you is a smart pillbox. So picture a blister pack of medications for the week, so up to 4 times a day, all 7 days of the week, that slips inside this pillbox. When it's time to take your next dose of medication, you perforate the top of that blister pack and you remove the medications from that well, as you can see in the picture on the bottom left. And on the bottom right, you can see an adherence report. So let's unpack this a little bit and talk about the different features of this smart pillbox. So first of all, and most obviously, it sends visual and audible med reminders. So in other words, when it's time for a patient to take their next dose of medications, that well of the blister pack lights up and a little alarm goes off, and then the pillbox then senses whether those medications are in fact removed from that well on time. If you do not remove the medications on time, then it can send a phone message, a text message, or an email alert either to the patient or to their caregivers, so for example, a family member, and let them know that the medications have not been taken, or at least not removed from the pillbox. And then it takes all of that information that it's learned over the course of the week and over the months that the patient is using the intervention, and sends that adherence data in a report to the patient's primary care physician. So there's a link that we put embedded in our electronic health record, which takes the PCP to that report, and that report is also available to a pharmacist case manager. So let's talk about the details of the intervention a little bit more. So the way that we did it is that the first month of meds was supplied by our hospital's outpatient pharmacy right before the patients left the hospital. Some hospitals call this a meds-to-beds program. This guarantees that the patient left the hospital with the correct medications and now with their blister packs and their smart pillbox. Subsequent medication trays were then mailed to the patient every 2 to 4 weeks, either by our hospital's pharmacy or by a collaborating pharmacy, depending on the patient's insurance. Any medications that are at risk for unexpected changes, so for example, warfarin or a diuretic in a patient with heart failure where that dose of the diuretic changes a lot, these meds are withheld from the pillbox because it would be too hard for them to change constantly if you're only getting a new shipment of trays every 2 to 4 weeks. In addition, any as-needed medications, so PRNs, opioids, or other controlled substances, are also not supplied in these pillboxes, in these medication trays. We had a pharmacist care manager that would call the patient if it was evidence of non-adherence. So 3 days in a row of less than 80% adherence would trigger a phone call to the patient and see how things are going. And then the intervention lasted for 6 months. And at that point, we made sure the patient had a safe landing back either to their usual pharmacy. They could continue to use just the blister packs without the pillbox, if that's what they liked. And if they really, really wanted to use the pillbox, the company that supplied it was willing and generous enough to let them continue to use it for an indefinite period of time. So the goals of our study were to implement the use of this smart pillbox in the transitional care setting. This kind of a pillbox has been used in the stable ambulatory setting in prior studies, but we wanted to see it in this particularly high-risk period of time when patients leave the hospital and go back home. We wanted to evaluate the effects of this intervention on medication discrepancies, on adherence, and on markers of chronic disease control, and also determine barriers and facilitators to implementation. And this study was approved by our Primary Care Practice-Based Research Network, our PBRN. So here's the design of our study. So the inclusion criteria included adult English or Spanish-speaking patients who were admitted to our general medicine, cardiology, or oncology teams, were on 5 or more chronic medications, were going to be discharged home, and had a primary care physician in one of our participating hospital-based practices. And we have a number of those. We then randomized by practice to one of 3 arms, so the smart pillbox, to a normal pillbox, so we can see the incremental benefits of the smarts of the pillbox, and then the third arm was usual care. And the goal was to enroll 133 patients per arm. Outcomes were followed for 6 months and included the following. So discrepancies between the regimen that is documented in our electronic medical record, so what are they supposed to be on, and what was actually being dispensed, either by their usual pharmacy or by our pharmacies filling these medication trays. Medication adherence, and we'll talk about what that means in a few minutes, and measures of chronic disease control. And the intervention lasted from January 2017 to June of 2018. So there were roles that a lot of providers in our system had to do in order for this intervention to go smoothly. So on the inpatient side, the inpatient team had to perform discharge medication reconciliation and send those prescriptions to our outpatient pharmacy as early in the discharge process as possible so that the pharmacy had time to do what they needed to do. They would then send an electronic message to the PCP or the specialist with the planned outpatient regimen. And this was based on feedback from our PCPs who said, you know, if you do discharge MedRec incorrectly, or I don't like what you've discharged the patient on, and I've got to change it 3 days later, and you've given me a pillbox where I'm stuck with that regimen for 2 or 4 weeks with that patient, that's going to be a problem. And so this was our compromise to say, okay, we'll make sure that you agree with the regimen before we send the patient home so that you're unlikely to change it when you see them back in the office the following week. And then finally, the inpatient team had to complete a bedside medication delivery form. This is what triggers the Meds to Beds program, providing an estimated date and time of discharge. Note if there are going to be any anticipated last-minute changes to that discharge medication regimen, right? Sometimes you're waiting on, like, what's that last dose of furosemide going to be before the patient leaves, so to give the pharmacy a heads up that might change. And then note if any of those medications needed to be withheld from the pillbox due to risk for unexpected changes. In terms of getting the adherence report, so it was available from a native screen within our electronic health record. So to a PCP, it just looks like it's built into our EHR. It would then provide a link to the adherence report login screen. And the default login and password was the same as the provider's credentials in our regular electronic health record where possible. It wasn't always possible, but for the most part, hopefully it was something that the PCPs could remember so they could get into that adherence report. So let's look at the adherence report. So by clicking on the dashboard, the providers would see at the top, first, the list of all the patients who needed outreach, so those who had 3 days with less than 80% compliance. And then if you scroll down further, the providers would see their full list of patients that were involved in the study. And then if you click on one of those patients, what you would see is an adherence report. So as you can see here, just an illustration, this graph displays the percent of doses taken based on the pillbox information over the previous weeks. And you can see every dot is a different week going back in time. And then you can adjust the time frame by, instead of clicking on the weeks button, you click on the months button, and then you can see it month over month. Remember, all of this information is being sent over the airwaves through a cell phone signal and captured so we can tell people how they're doing over time. And then this is what I call the heat map. So this tells you exactly which wells of the medication tray the patients took and which ones they didn't take. And so this, in this first view here, this is in a given week. You could each of the 4 times a day, each of the 7 days of the week. Did they take their pills on time? Did they not take their pills on time? And then you can also see how late or how early they took the medications compared to when they were supposed to, when the alarm goes off. And then in aggregated format, you can see, over the course of weeks, which particular days of the week, which particular times of the day are patients having trouble with. So if in this particular example, you see the patient never takes their medications on Saturdays, and they're all dark blue, while there may be some other times of day, other days of the week when patients are more likely to be adherent and to take their medications out of the tray. So what was the role of the outpatient provider? So we encourage PCPs or the practice managers in their practices to review these adherence reports periodically. And if they saw evidence of non-adherence, we suggested that they engage their patients as the practices saw fit. If the collaborating pharmacy did reach out to patients, because remember, we were tracking this in the background and contacting patients if they were not adherent, they would write a note about the outreach that they did, and then we would add that to the patient's chart. And then finally, if there were discrepancies between the EHRs and the pillbox's medication list, so when it was time to send a new supply of medication trays, then the practice would be contacted to try to resolve those discrepancies. So in the ideal world, the pharmacy was always sending out the regimen that the patient was supposed to be on, at least according to our electronic health record. Outcome assessment, as I said, was during the 180 days after discharge from the hospital. The first outcome were medication discrepancies. So again, are there differences between what was being filled by the pharmacies and what the active medication list said in our electronic health record at any moment in time when those medications when those prescriptions were being filled? The second outcome was medication adherence, so using proportion of days covered, PDC, just like in the previous talk you heard. And then we did a different measure of adherence called the daily polypharmacy possession ratio, which I can get into details during the Q&A if you're interested. But basically the idea is that on every single given day, you say, okay, how many medications is the patient supposed to be on that day, and how many of those medications did the patient have a supply of based on the prescription refill patterns? So it's a little bit more nuanced than a PDC. And then finally, we looked at measures of disease control. So if the patients had hypertension or diabetes or high cholesterol, we looked at their blood pressures, their hemoglobin A1Cs, and their LDLs, respectively, over the 6-month period. In specifically the intervention arm patients, we looked at a few other things. So, for example, what portion of their medication regimens were we able to put in the pill trays? How good was our on-time delivery of trays? How often did providers use these adherence reports? And then how often did they document that they actually took action in response to those adherence reports? And then what we're doing right now is qualitative analyses. So we are interviewing patients inpatient providers and outpatient providers and asking them about the perceived effects of the intervention on patient care, on workflow, about barriers and facilitators of implementation, and then finally suggestions for improvement. So here is the flow diagram. So we assessed 961 patients for eligibility, of which 719 were eligible. The ones that were not eligible were mainly because they were unlikely to be discharged home or they weren't on 5 or more medications. Some of them have cognitive impairment and no healthcare proxy. Of those 719, 512 were not enrolled. 401 patients declined. 85 patients we were never able to approach. They were discharged before that time. And so that led us to 207 patients who were randomized. Because we were having trouble randomizing enough patients, we actually ended up getting rid of the basic pillbox group, so Arm 2. So those 24 patients that you can see in the middle group there, we ended up excluding from the study. So that gave us enough patients so we could really do the main comparison, which was usual care compared to the smart pillbox. As you can see, 73 patients were allocated to the intervention, 93 were allocated to usual care. Of the ones allocated to intervention, as you can see, we had 15 post-enrollment exclusions because those patients in the end were not actually discharged home or were on fewer than 5 medications. Of those 73 who were allocated to the intervention, 40 actually got it. 33, unfortunately, were unable to because they were discharged over the weekend when our hospital pharmacy was closed, or there wasn't enough time to receive it, or we had staffing issues, and I'll talk about some of these logistics in a few minutes. And then, as you can see, of the 93 that were allocated to usual care, only 1 withdrew. And then, again, in terms of, that's who received the intervention or usual care. And then in terms of, again, those who were allocated to the intervention, 12 patients stopped the intervention early, either because their PCP wanted them to, the study team felt like it was unsafe for them to continue to use the pillbox, their patients sometimes withdrew. But we still analyzed 72 out of the 73 patients, everyone who didn't withdraw from the study. So this is an intention to treat analysis and compared to the 93 who were allocated to usual care. Okay, so let's talk about some of the barriers that we encountered, and as you can probably get a sense from this flow diagram, there were a lot of barriers. So the first set of barriers are about enrolling patients in the study. So, so as you can see in this table, we have the barrier and then how we try to solve that problem or should try to solve that problem in the future. So the biggest one that we found about enrollment was that patients denied that they had any previous problems with adherence. And even though we know, again, from some of the things that were said during the last talk, that 50% of patients are not adherent with their meds, but there is a lot of pride. There's also a lot of shame and a lot of guilt around patients' non-adherence. And so it was tough sometimes to break through that, especially if, now we say, well, we have a system that's going to be monitoring your adherence really, really closely. Some patients just didn't want to be a part of that. And so we did a lot of scripting to try to reduce the stigma of accepting this intervention, saying we're going to give it to everybody just because you're on 5 meds and going home. We didn't, pick you out of a crowd because we knew you were having problems with adherence in the past. Sometimes we tried to leverage patients' caregivers or providers. If the patients were kind of in denial, but maybe the other 2 were in our court and saw the need for this intervention. Perceived portability issues with the pillbox, it is kind of bulky, and for patients who leave the home a lot, some of them didn't want to enroll in the study for that reason, and so we talked to patients that they could always remove the pills, out of the tray early in the day and just keep them with them, wherever they travel, but that was definitely a barrier. Too many medications dispensed outside the pillbox, right? You hit some kind of threshold in a patient's mind where they say, well, so many of my meds are not in the pillbox because they're controlled substances, or they're insulin injections, or they are that dose of furosemide that changes a lot, then they don't see the value of the pillbox anymore. And so we were able to provide text reminders for non-pillbox medications to remind them to take them so they still had that benefit. And then there was a lot of patient education that we tried to provide about using the pillbox under different situations. It was possible for some patients' copayments to increase. So if they were doing 90-day fills and now they had to go down to 30-day fills for these medication trays, sometimes that meant that the copayments went up. And so we did emphasize that the benefits of the intervention may be worth the copay increase. Some patients believed that, some did not. And then, of course, there are always going to be some patients who are resistant to participating in any kind of research study. And so, we tried to highlight the benefits to patients and to the general public, appeal to their sort of altruistic side. What about barriers at discharge? So the biggest barriers here were around logistics. So, as I said, one of them was turnaround time. So the pharmacy often received discharge prescriptions for patients less than 2 hours before the anticipated discharge, and this just did not give them a lot of time. And so we encourage clinicians to provide the prescriptions as early as possible, to do discharge med-rec as early as possible, facilitate early communication between the pharmacist and the clinician. The time required to dispense initial medications and enter the information into the pillbox application was actually pretty long. And so what would really need to happen is develop software interfaces to just speed that amount of time to get the data into the system, to use to both interface with our EHR and with our medication dispense system. As I mentioned during the flow diagram slide, our outpatient pharmacy, as a lot of outpatient pharmacies are affiliated with hospitals, are closed on weekends, and they close at 5 or 6 o'clock every night. And so this made it hard for patients who were going to go home during those times. We did develop protocols for patients who were discharged over a weekend to return on Monday to get their pillbox, but not every patient wanted to come back. And then lack of insurance coverage for early prescription refills, right? So if a med was filled right before the hospitalization, and now you wanted to fill it again so you could put it in the pillbox, that costs money because the insurance would deny the early refill. We had a fund to cover those costs, but that would be hard to reproduce in the future. And you're not allowed to take the pills out of a previously dispensed bottle and stick them in a medication tray. Most states have regulations against that. And finally, there were barriers after discharge, difficulty reaching patients to confirm those refills, so we tried to reach patients in a variety of ways. Difficulty obtaining prescription refills from providers, especially if there are multiple prescribers per patient, and so we had to develop a bunch of standard operating procedures to make sure we got those prescription refills. Sometimes there were issues with pillbox connectivity, so poor signal in some locations, and sometimes we had to work through with patients where to put the pillbox in their home, so if the cell phone signal was the strongest, to send those adherence reports. And that will also be fixed with future pillbox enhancements. And then finally, sometimes if it was just one small pill in a tray in a well, the pillbox would not detect that pill had been removed. And so again, some planned enhancements. We also tried to group medications in those different wells to prevent this from happening. So what would it take to make this intervention part of usual care? Well, if it's no longer a study, several issues go away, right? There's no more the issue of resistance to participating in research. The issues around stigma and denial may or may not go away, but it may help if the intervention is recommended by one's own providers as opposed to a researcher. The logistical issues, as I said, were prominent. Some would be resolved by productization, right? So if we worked harder to ensure compatibility of the pillbox software with our electronic health record and with our medication dispense system, that would definitely help. Having multiple pharmacists who can program the software, dispense blister packs, take advantage of efficiencies of scale. We would definitely need more concerted efforts to facilitate communication between clinicians and pharmacists and provide those prescriptions early. Some of the logistical issues are harder to correct. So this tension between the time constraints to set up an electronic pillbox and the rush and the unpredictability of hospital discharge, definitely paramount. And then the restricted hours of most hospital-based pharmacies make weekend and discharge, evening and weekend discharges challenging. Some issues may require more systemic changes, right? So should insurance companies and can insurance companies agree to a waiver of an early refill and a reduction in co-payments to 90-day levels in exchange for using this intervention because it really does improve adherence? Is there a sustainable business model for pharmacies to do the extra work? And if not, who pays for it? What about the former pharmacies that used to fill up patients' meds but now have been taken out of the loop? They may object to the loss of business. And, this is really a paradigm shift. We're talking about regimen-based prescribing as opposed to medication-based prescribing. Is it okay for an antihypertensive to not change for 2 weeks until the new shipment of trays arrives in the patient's mailbox? And then some issues require iterative technological improvements. So things about signal strength, pillbox connectivity, thresholds for detecting pill removal, portability. And then finally, some patients may not be ideal candidates for the intervention. And the question is this the best time to initiate this intervention? There are a lot of advantages to doing it at the time of hospital discharge when we know so many things go wrong with patients' medication regimens. On the other hand, is it logistically really just too hard to do this at the time of hospital discharge? So our next steps are to complete our interviews with patients, PCPs, and inpatient providers, complete our outcome assessment, work on dissemination activities. And in conclusion, a smart pillbox has the potential to decrease med discrepancies and improve adherence. Otherwise, ideal candidates may resist this electronic intervention for a variety of reasons. And some patients may not be ideal candidates because of frequent travel or the nature of their regimen. Many patients have been really pleased with this service. We really did make a difference in a lot of patients, and we're looking forward to looking at the outcomes. And although logistically difficult, the potential benefits of using this intervention during this high-risk period of hospital discharge may warrant further efforts to modify and refine discharge workflows to really make it possible. So I want to thank all of my collaborators, and this is just a partial list of them without whom this study would have been impossible. And here's my email address if anyone has questions afterwards, and I'm looking forward to the question and answer session at the conclusion of this presentation. So thank you so much for listening.
Thank you, Dr. Schnipper. As a reminder, we will be taking questions after the presentation, so please submit any questions you have for Dr. Schnipper using the Q&A panel. Let's move on to our final presentation of this webinar, which is being led by Dr. Margie Snyder. Dr. Snyder is an associate professor of pharmacy practice at the Purdue University College of Pharmacy. She received her Doctor of Pharmacy and Master's of Public Health degrees from the University of Pittsburgh. Dr. Snyder's expertise is in community pharmacy and health services research, and her research is focused on strategies for optimizing the delivery of medication therapy management through application of qualitative and mixed methods. And now, I would like to turn the controls over to Dr. Snyder.
Thank you, Dr. Wyatt. As Dr. Wyatt said, my name is Margie Snyder, and I'm an associate professor at the Purdue College of Pharmacy. And I'm the principal investigator for an ongoing AHRQ-funded health IT study called Enhancing Clinical Decision Support Applications for Community Pharmacist-Delivered Medication Therapy Management. The aims of this study are first to evaluate the extent to which computerized clinical decision support, or CDS, for community pharmacist-delivered medication therapy management aligns with established human factors principles, and two, to assess the usability of MTM CDS for community pharmacists, as well as pharmacist perspectives on the usefulness and usability of these technologies for patient care. During the webinar on September 13th, I did present more information about this study. However, due to concerns from potential journals where manuscripts from this project would be submitted, they've asked that we wait to make the complete slide deck available. So therefore, if you have any questions regarding this research, please don't hesitate to reach out to me, and my contact information is there on the slide. Thank you.
This concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type them into the Q&A section of the WebEx portal. We may not be able to get to all of them. However, we will answer them all in writing and forward them out to all the attendees. So the first question I have is for Dr. Farris. A participant asks, how does the RL agent make decisions?
So the RL agent makes decisions based on a set of computations that are engineer built. And so it's taking information about baseline characteristics of the patient. So we actually ask them about their beliefs in treating their hypertension, their the extent to which they thought their antihypertensive was necessary. Their concern beliefs. So we ask those baseline values or baseline items as well as other demographic information. And then we set the agent originally based upon their responses to those. So if a person said they didn't really think they needed their antihypertensive medication or they were lower on that item, we would send them a lot of necessity messages, because the agent would say, oh, here's an area where we think we set it up that way. Then over time, the agent is learning what kind of message is working for an individual, and that's based upon a set of computations that sit within, and algorithms that sit within the agent. I'm not sure if that answered the question. It's as close as I can get right here. How about that?
Oh, thank you. The next question is for you also, Dr. Farris. Can you talk a little bit about the cybersecurity precautions that was applied to the technology you researched?
Yeah, that's a really good question. So if you remember that diagram that I showed you about the entire system, so the entire system was sitting within our health system, which it has servers that are protected. So that kind of data was managed in a HIPAA-compliant environment. In terms of texting, we did not include information that that would have been HIPAA, that would have been a PHI problem. I know that now we can do HIPAA-compliant texting, and I think in future applications we definitely need to do that. But we were very cognizant at the time that we did not need to put in a message that said, "Hey, Karen, take your you need to be taking your whatever medication for your high blood pressure," so that we would name the patient, we would name the drug, and we would name their condition. So we did not tailor, for lack of a better word, messages to that degree because we didn't have a HIPAA-compliant text program at the time. Those do exist now.
Okay, thank you so much. Dr. Schnipper, the next question is for you. Do you have any preliminary results on the impact of the pillbox on patient care?
Yeah, that's a great question. We're just looking at the data right now. We certainly have some anecdotal stories of patients who were very effective users of the pillbox and really found it incredibly helpful. The convenience of having their regimens mailed to their door, the reminders being there. Fewer stories about the caregivers, being part of the solution, which was not what I wanted to hear. I really wanted to hear that caregivers were now much more involved in care because, they would get that text message, for example, that their loved one didn't open their pillbox on time. But the final results we're analyzing as we speak. I think some patients benefited incredibly from this, but not all did. And I think what we really need to look at is, who are the kinds of patients who benefit the most from this kind of an intervention? It's certainly not for everybody, but if we had that better idea, then we could certainly target this, much more efficiently. So, so stay tuned. We'll know more soon.
Thank you. We will look forward to the results that you have. The next question is also for you, Dr. Schnipper. If you had to do the study over, what would you have done differently?
Yeah, that's a great question. Most of the studies that I work on are considered low-risk studies from a human subjects standpoint, which means we can have a non-clinician research assistant enroll the patients in the study. However, in hindsight, the logistics of pulling this study off are so embedded in how our healthcare system works and how our hospital works that I actually wish we had had a clinician be the one enroll the patients in the study and then trigger all the subsequent actions that needed to happen, both the inpatient team and the hospital pharmacy team, because it does really require a level of sophistication in order to anticipate what problems might occur and to prevent them from occurring. And so I think that's probably the main one that I took away from this. There are others as well, but I think that was probably the main one. Would be to have an actual clinician enroll the patients in the study from day one.
Okay, thank you for sharing that with us. Dr. Snyder, the next question is for you. How do findings and recommendations vary by alert type? For example, safety-related alerts versus adherence-related alerts.
Yeah, so that's actually something that we're still looking into. But as I did note on the one slide, although all of the alert types scored similarly as far as the numerical score on the modified IMADISA, we did see a slightly better score among the adherence alerts. And on the slides where I indicated the tables of our findings thus far, in situations where it would say most alert categories versus all, we did find the exception was for adherence alerts. So it's interesting that there do appear to be some heuristics that were better met among our adherence alerts compared to other alerts, and that's something we're continuing to consider and think about.
Thank you. We also had a question for you in regards to the study was focused on community pharmacists as the end users, but pharmacists have varying levels of experience with MTM and are often supported by other types of users, such as pharmacy residents and students. Can you kind of speak to this?
Yeah, that is something that We noted as well in the prior AHRQ-funded study that I mentioned, as it was seeing this kind of influence of the user type and how they interface with CDS. You're correct that for this study, we did focus on community pharmacists. I think we had maybe one community pharmacy resident that participated. However, we do actually, since we started this study, we have worked to collect some additional data for a follow-up study where we've interviewed both community pharmacists as well as community pharmacy residents, and we're currently analyzing those data to better understand their information needs as they're completing a medication therapy review, so we can think about how we might be able to best design CDS that could better meet the needs of different user types.
Okay, thank you. Dr. Farris, the next question is for you. Is the pill bottle opening a good reward for the agent?
That is an excellent question, and in my opinion, it is not. It may be a good reward when there's true variability in adherence, but when adherence is as good as ours was, all the messages end up with the same usefulness because individuals are opening their pill bottle. So a reward that is really more clinical. So I mentioned the number of steps. If there's a way that you could have a blood glucose, if you were doing something in diabetes, I think we've got to think about what those better rewards are for an agent in future work. Well, we have thought about it, and that's my point right there.
Okay, thank you. Dr. Schnipper, the next two questions are for you. The first question is, can you talk some more about the pros and cons of initiating this intervention at hospital discharge as opposed to stable ambulatory patients?
Absolutely. You certainly, from a logistical standpoint, there's no question that this is easier to do in a stable ambulatory patient. You can wait until most of their prescriptions are going to be up for renewal and therefore will not be denied by their insurance when it's time to, refill them. You can pick a stable moment in time when it's a good time to, set all this in motion. You probably have a couple of days to set up the pillbox, program the software, fill the blister pack so there's not this crazy rush, and then, just have it mailed to the patient's home. On the other hand, there's probably also less immediate benefit. If we know in reality right now at the time of discharge that 3 days after discharge, half of our patients are taking the wrong regimen, and even when they know what regimen they're supposed to take, another half of them aren't actually taking it. There's such potential for benefit. So I think, the stakes are higher. It's much more complicated, but I think the benefits are also higher as well at the time of discharge. And so the question is, can we get through these logistical problems to benefit patients more? We're going to know more when we finish, crunching the results of the study. If those logistical issues were so paramount that we couldn't actually see a lot of benefit in the transition setting, then I would say we should just go back to doing this in stable ambulatory patients. But my guess is that in the real world, there'll be patients in both settings where we're going to want to initiate this kind of an intervention. It's not for everybody, but I think for the right patient, you could do it in either setting. But you just have to be aware of what the logistical issues are if you're going to do it during a transition in care.
Okay, thank you. The second question is, do you know if the smart box data was able to be used in the ED area to obtain trauma or unconscious type patient meds?
Yeah, that's a great question. I saw that in the Q&A panel. So picture a patient is unconscious. You don't know what medications they're on. If you could get access to this adherence report and say, oh, okay, this is what they've been, taking and really taking because it's all in their pillbox and when they've been opening their pillbox, that'd be really valuable information for someone to know. Again, could they be taking some meds outside the pillbox? Absolutely. So it may not be 100% complete, but it still would tell you a good deal of information. I think that's a great use case for this. And as as the Internet of Things kind of explodes over time, I think we're going to know a lot more about patients, and we have to be careful about issues around cybersecurity, of course. But all kinds of use cases where you can see the benefits of this. Someone did ask me a question about cybersecurity, and this is completely secure information. You can't hack into a smart pillbox. However, obviously there are always these concerns anytime you're sending stuff over the airwaves.
Okay, thank you so much. And I think this is going to conclude the question and answer period for us. We're going to close out the webinar from here. We have reached the end of our time for this webinar, and thank you for all attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on the slides. You will select today's webinar, which will be indicated by the date and title, and then complete a brief evaluation of the event to claim your credits. You will have 14 days to claim your credit for participating in this webinar. Please claim your CMEs by September the 27th, 2018. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will be able to complete this survey to share your feedback with us. Thank you all very much for participating in this webinar today, and we hope you will join us for future learning opportunities.